From the JAMA Network, this is JAMA Ophthalmology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Ophthalmology.
Hello and welcome to this author interview from the JAMA Network. I'm Neil Bressler, Editor-in-Chief of JAMA Ophthalmology, and today we're going to look at a recently published paper in JAMA Ophthalmology on the risk of non-arteritic anterior ischemic optic neuropathy in patients who were prescribed semaglutide. Semaglutide belongs to a class of medications that are known as glucagon-like peptide 1, or GLP-1 receptor agonists. Semaglutides were approved by the U.S. Food and Drug Administration, the FDA, over the past several years for use in adults with type 2 diabetes. And more recently, many people have been taking it sometimes as an off-label medication for weight loss in the absence of diabetes. It's given as a weekly injection to help lower blood sugar by helping the pancreas make more insulin. Now, joining me for this fascinating investigation is the corresponding author for that paper, Dr. Joseph Rizzo. Dr. Rizzo is a professor of ophthalmology at the Massachusetts Eye and Ear Infirmary of Harvard Medical School in Boston, Massachusetts. Joe, thank you so much for joining us.
Thank you very much, Neil. I'm so happy to be here.
Joe, you said that anecdotal experience really raised the possibility that semaglutide was associated with non-arteritic anterior ischemic optic neuropathy. What exactly was that anecdotal experience that you and your authors are referring to?
Thanks for asking. It's a nice reflection to think about how this got going. But in my office, we have a common area where the physicians meet when we see patients. And we were talking at lunch, and a resident came up from our emergency room, hearing the story of a patient whom I had just seen who had NION, ischemic optic neuropathy, and who was taking a semaglutide drug. She said she had just seen one in the emergency room the day before. And within the next week, I saw a third patient. And because NION is a fairly uncommon disorder in the general population, the fact that we had three within a relatively short period of time led me to suspect that there was a higher risk of developing NION in patients on semaglutide. That's when we began to think about how we would conduct a study.
So how exactly did you begin to investigate this? What exactly did you do to figure out, were these just three coincidental cases, or was there really possibly some increased risk for patients who were taking these semaglutides? What was the method you used to begin to investigate that?
That's also a great question because it's non-trivial to try to do this. And fortunately, my research assistant for last year, who was going to be one of our clinical fellows in neuro-ophthalmology starting next week, she was obtaining an MBA from the Harvard School of Public Health. And she was my research assistant, and we began to talk about this. So I had access not only to her knowledge, but we then met with the senior professor of public health at Harvard Medical School to think about how to structure the study. As in any research, the most important time of the research is before you do it, to lay out a strategy for what would be seemingly the best way to approach the question. So that's what we did, and we developed the idea of doing a retrospective matched cohort study. This is the type of study that we could do out of our office. We have a fairly large number of neuro-ophthalmologists in the Harvard system, many of whom work at least part of the time out of my office. And all of the patients in this article were seen here at Mass Eye and Ear out of one office. So that's one of the strengths of the study. It also is nice because all of our group work together and have a similar style of practice. And so it was easy for us to collect and think about these cases. It was a retrospective study, and we went back basically to the time at which the FDA approved the first drug for semaglutide use. And then we did a digital capture of all of the unique patients we had seen over that 6-year period of time. So that's the process that we went through. And the other detail is we then separated patients who were treated either for diabetes or for being overweight, and then did an analysis of risk between those two groups.
So when you said you separated them, did you ever look at it as a whole, or from the get-go, you looked at this risk in people who have diabetes, who also perhaps have a risk of having non-arteritic anterior ischemic optic neuropathy, and then you looked at it separately in a group who did not have diabetes? Was that the plan, or did you look at the overall group and then also look at two subgroups there?
Yes, so with the digital database, we simply divided patients into those who had diagnoses of diabetes or being overweight. And obviously, there are a fair number of patients who are both overweight and have diabetes. So we did the best we could to separate these based upon the original indication for treatment, whether it was for diabetes or for being overweight.
So what did you find? Was there an increased risk? Were these just three coincidental cases that your resident had identified along with your fellow and in your practice? Or did you really find an increased risk among your practice that you're discussing at Mass Eye and Ear?
So there's clearly, in our view, based upon this work, an association between taking semaglutide and the risk of developing NION. And the risk is expressed in multiple ways. We did many forms of statistical analyses, but a classic way to do this is to define what's called a hazard ratio, which essentially gives you a numerical estimate of the risk of developing, let's say, NION, if you take semaglutide or not. So if you're a diabetic patient and you don't take semaglutide, or if you're a diabetic patient and you do take it, what's the difference in risk? So that is the so-called hazard ratio, and our numbers show relatively high hazard ratio. So for instance, for a diabetic patient, it's 4.6, meaning more than 4 times greater risk of developing NION. Now that sounds like a high number and is surely a significant number, but NION is a relatively uncommon disorder, right? So you have to take it in that context. The other thing, Neil, if you don't mind, I'd like to emphasize that what we have described is an association. And that term is really important because we're not suggesting, we don't have the evidence to assert that there's a cause and effect relationship between the two. That would require additional study with a much larger number of patients in a different methodology.
I appreciate that emphasis, and I think that is very important for our listeners. So was the risk similar among the people who had diabetes and among your group who were taking these medications and did not have diabetes? Or did you find that this hazard ratio was different in one group versus the other?
Yes, well, it is different. So, for instance, I just offered the number roughly 4.5 hazard ratio for patients with type 2 diabetes. For those who were being treated initially, at least because of being overweight, the hazard ratio was 7.5.
So quite a significant increased risk. And I know you said this certainly does not determine cause and effect, but do you have any biologic rationale for why this may have occurred? And were there any theories that included that biologic rationale before you undertook this investigation?
So the answer on both accounts is no. Really interesting because before we began the study, there wasn't an obvious reason to imagine there would be an association. And once we found this association, of course, we delved much more deeply into plausible mechanisms. And the long story made short is that we do not have a clear answer. Please remember that the cause of NION in general is not well understood. And so, based upon what we know about NION and what we know or are learning about semaglutide, we don't have a clear mechanism to explain this. I think it's quite remarkable that given the enormous degree of use and growing use of semaglutide across the world, and particularly in industrialized countries, it's quite notable that there have been relatively few significant side effects of these medicines. I mean, that's one of the more remarkable things. They've produced significant benefit for people, which accounts for their popularity, but relatively little downside. We do know of some, but really nothing, certainly nothing neurological that has been found to be a side effect of the use of these medicines. So it was quite, I won't say a surprise because we had a hunch, but it is a surprise in the sense that there isn't a background of other neurological complications that have occurred in association with the use of semaglutide.
So in the FDA label or in prior clinical trials, this was not something that was readily identified in any way.
Absolutely not. In fact, we did our best to search the available information on the FDA site, and there was no evidence of this previously reported.
And we often hear that non-arteritic anterior ischemic optic neuropathy may be seen in association with crowded discs, so to speak, a zero cup to disc ratio. Was there anything unusual about these cases? Did they otherwise look like your typical NION cases of a crowded disc, of occurring in one eye and perhaps also in another eye? Or did their phenotype somehow stand out as a little atypical for NION? Or have you not had a chance to look at that yet?
Well, because we all practice together and we've looked over these cases together, these were absolutely typical cases of NION. Absolutely typical. So again, we don't know the mechanism. That local anatomical factor of the small cup to disc ratio, the so-called disc at risk, that's the best evidence we have about a causal factor in NION is the cup to disc ratio. But why that would be relevant to the mechanisms of semaglutide is not clear.
So I presume this should not necessarily change our practice. We shouldn't start telling people this is a known side effect of the medication, but I assume you want to look at this in other cohorts or at other institutions or in other ways. What are you all thinking about the next steps to see if this can be confirmed or if it's just a fluke that was seen in this cohort at Mass Eye and Ear?
So we've spent the last couple of months as we finished this article and submitted it. We then went back to the original professors at the Harvard School of Public Health, and now they've introduced us to a couple of other pharmacoepidemiological experts, and we're beginning to explore what we might do next. There are several options. I mean, ultimately, the next step has to include a much greater catchment of patients. There's no way around that. We need more patients. And herein is a very significant challenge for that type of study. So NION, the disorder of NION, is diagnostically coded under ischemic optic neuropathy. That's a broad category. In a neuro-ophthalmic practice like ours, a large fraction of the patients that we code as ischemic optic neuropathy, in fact, have giant cell arteritis. And they get coded the same way. There is no diagnostic code for NION. So what it required was for us to go back and perform a manual review of these charts to confirm, in fact, that the diagnosis was NION. Now, we could perhaps continue a manual review for a larger catchment of patients, but at some point, that becomes an untenable approach. So if one wanted to, let's say, do a national Medicare-based study, you would not be able to do it with the diagnostic accuracy that we had here. Now, some of our neuro-ophthalmic colleagues, having previously recognized this problem, have developed an algorithm that incorporates text searching into the electronic record. And thereby the diagnostic accuracy can be improved over what it is without doing the text search. But it's not as accurate as doing a manual search. I should add that we also did a text-based search to make sure we were capturing all the patients with NION. But after that, we then did a manual review. So you can see there are some really logistical challenges to doing a larger study. But right now, we haven't yet decided. But in one form or another, a larger study, I think, will have to be done.
Well, this has just been a fascinating road to perhaps something that will be confirmed and very important to know as the use of these medications perhaps continues to grow. And I just thank you so much for sharing your investigation, your insights, and your additional time for our podcast.
Thank you so much. Well, I'm glad to talk with you, Neil, and glad to share our research outcomes with your audience.
We've been listening to Dr. Joseph Rizzo, who has shared his insights on a recent publication in JAMA Ophthalmology, for which he is the corresponding author, on the risk of non-arteritic anterior ischemic optic neuropathy in patients prescribed semaglutide. Joe, thank you so much again for spending the time with us.
Thank you, Neil.
This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.